Hello, good evening, friends. Welcome back to the channel. And today we'll be discussing benign thyroid disorders along with hyperthyroidism. So, without further delay, let's get started. So, hyperthyroidism is a feature where the thyroid hormones are more in the body. And how do they present to us with? They have features of that the patients are generally thin, they are irritable, and sometimes or most of the time they will be having heat intolerance. They will not be able to tolerate heat. Then these patients will also be having loss of weight in spite of having good appetite, like they will be voracious eaters but they will be losing weight and henceforth they will be thin. Then some cardiac features, like they will be having tachycardia and palpitation. Then GI symptoms, that is diarrhea, multiple bowel movements. Then neurological, that is tremors, and gynecological, that is oligomenorrhea is more common than menorrhagia. So these are some of the symptoms of hyperthyroidism. We'll just go through that. The patients are thin, they are irritable, have heat intolerance, they'll be having weight loss despite having good appetite, tachycardia, palpitation, diarrhea, tremors, oligomenorrhea, menorrhagia. Then coming to their thyroid function test, in cases of hyperthyroidism, the thyroid function test, they will be having raised T3 and T4 and low TSH. So low TSH is very important factor. So these hyperthyroid patients, they will be having low TSH. So it follows a negative feedback mechanism. So the TSH secretion will be decreased as there will be raised T3, T4. Now coming to the causes. So what are the causes of hyperthyroidism? The most common being the Graves' disease, also known as primary thyrotoxicosis. So we'll also see what is secondary thyrotoxicosis or secondary hyperparathyroidism over some time. Then we have the others like the solitary toxic nodule, toxic nodular goiter, also known as Plummer's disease, factitious hyperthyroidism due to increased thyroid hormones intake, then Jod-Bezdo phenomena due to increased thyroid hormones due to iodine in the body, raised iodine. Then TSH secreting pituitary tumors, so there will be raised TSH. So this is a special case where there will be raised TSH, and then there will be again T3, T4 rise. And lastly is stroma ovary, where there will be ectopic thyroid tissue in the ovary. So here the ovary will be having some thyroid tissue which will be causing more thyroid hormones. Now these various causes, how will they appear on the thyroid scan, the radioiodine scan? So in Graves' disease, there will be diffuse uptake increase. So there will be diffuse complete uptake increase. Then the solitary toxic nodule. Here there will be single hot nodule. So only one nodule will be clearly visible, as we have seen in the previous video. Then we have the toxic nodular goiter, so there will be multiple hot and multiple cold nodules. Then in factitious hyperthyroidism, where there will be increased thyroid hormone intake, there will be decreased uptake. So here, because the thyroid hormone is already more in the body, so the thyroid gland will be not functioning at a higher rate because there is already a lot of hormone. Then Jod-Bezdo phenomena, here there will be increased uptake. Then TSH secreting pituitary tumor decreased, diffused increase, again as similar to the Graves' disease. Then lastly the stroma ovary, where there will be decreased uptake in thyroid gland. So these are some of the thyroid scan features of various causes of hyperthyroidism. Then here thyroid, how do we manage these? So we can either manage them by only drugs depending on the cases or cause or the age profile. Then other way of managing hyperthyroidism is drugs followed by radioactive iodine ablation or surgery. So we can either go for surgery or radioiodine ablation after drugs. So these are some of the ways of managing hyperthyroidism. So what are the common drugs? So commonly used drug is propyl thyrouracil, that is PTU, which inhibits the thyroid peroxidase TPO enzyme, which helps in making of the thyroid hormone. And this drug is safe in pregnancy and lactation. Then the second one is carbimazole. It also inhibits thyroid peroxidase enzyme. And these drugs are very useful before doing any other treatment so that the patient becomes euthyroid and we can prevent thyroid storm. We'll be seeing that in detail too. So it is important that the patient becomes euthyroid and is not hyperthyroid before any intervention, that is either surgery or radioiodine ablation, to prevent occurrence of thyroid storm, sorry. Then we follow radioiodine ablation after drugs. So what do we use here? That is iodine 131, which gives beta rays, and the half life is 8 days for beta ray, this 131, iodine 131. And other times we can go for surgery. So how do we prepare the patient for surgery? So first of all, we give the antithyroid drugs which we have discussed for 6 to 8 weeks, that is around 2 months. Then we combine them with beta blockers so that the clinical features are masked. So antithyroid medication are combined with long-acting beta blockers. So there'll be super sensitization of the sympathetic receptors. So what do we use as long-acting beta blockers? Nadolol, which is commonly used as OD dose, and we give this drug, that is the antithyroid medication, 1 day before surgery, that is previous evening on the day of surgery, before the day of surgery. And beta blockers are administered on the day of surgery preoperatively and should be continued after surgery up to 7 to 8 days, because these are important to prevent the thyroid storm. So, and 10 days before we also start Ki or Lugol's iodine, that is given to decrease the vascularity, which will be helpful for maintaining bloodless or minimal blood loss during surgery. Then coming to thyroid storm, which we just discussed. So here there will be uncontrolled thyrotoxicosis, uncontrolled symptoms, uncontrolled clinical features of hyperthyroidism. And what are the features? So there will be excess heat, that is hyperpyrexia, excess temperature, dehydration, then palpitation, hypertensive crisis, altered mental status. So all these are features of thyroid storm. And the palpitation, which may result in which are due to arrhythmias, can also cause death. So it is important. So, and this can also occur after any surgery who are on thyroid hormones and are not properly controlled, not having proper thyroid control and not proper levels of TSH, proper thyroid hormone status in the body. So even after other surgeries, there can be thyroid storm. So we have to be careful. So what are the causes? So as we discussed, inadequate preparation before surgery, especially thyroid, and also others. Others are URTI due to viral infection, trauma or surgery, anesthesia, drugs, acute iodine load, abrupt stop of antithyroid drugs. So these are some of the triggers or factors for hyperthyroid crisis or thyroid storm. So how do we manage these cases of thyroid storm? So first of all, we give IV fluids. Sometimes these are cold IV fluids to manage hyperthermia, oxygen, antibiotics, and management of hyperthermia by cool blankets, IV steroids, IV propranolol, antithyroid drugs like propylthiouracil, carbimazole, Lugol's iodine, and cholestyramine. So these are some of the ways or management principles for thyroid storm. Now coming to, as we have seen that primary thyrotoxicosis is due to Graves. So these are also known as primary hyperthyroidism. So we will see what is primary versus what is secondary hyperthyroidism. This is, so the primary as in Graves, which we'll be seeing in detail. So primary hyperthyroidism, these cases are autoimmune cases, and the secondary hyperthyroidism, these are autonomous nodules. So in multinodular goiter, some nodules start functioning more and causing autonomous secretion of thyroid hormone, autonomous nodules, and these cases primary are younger and secondary are old patients. And in primary, the swelling, goiter, and the toxic symptoms of hyperthyroidism, they appear together generally. And here in secondary, since it is known that it is secondary, that the goiter appears first and the toxic symptoms, that is the toxic symptoms of hyperthyroidism, appear much later. Therefore it is called secondary hyperparathyroidism, where the hyperthyroidism is secondary to the goiter after some years of appearing of goiter. Then in primary, the toxic symptoms are abrupt and very severe, whereas in secondary, the toxic symptoms are insidious, slow onset, and mild. In primary, the neurological symptoms will be more severe and more pronounced, and the cardiovascular will be more pronounced in the secondary. The goiter, the swelling will be soft to firm and moderately enlarged and will be diffuse generally. So as in Graves' disease, and whereas in secondary it will be nodular or multinodular, variegated, and also be quite large. So lastly, the eye sans, which will be more prominent in the primary and less common or even sometimes absent in secondary. So these are some of the differences of hyperthyroidism in primary versus secondary. Now coming to the Graves' disease, which is the most common cause of hyperthyroidism, also known as primary thyrotoxicosis. These are caused due to antibodies against the thyroid receptors, and it is an autoimmune condition where the self antibodies are acting against the receptors. So there will be LATs, that is long acting thyroid stimulating antibody, causing increase in thyroid hormones, and it will be associated with pernicious anemia and myasthenia gravis. These both are also autoimmune conditions. Now to go into the clinical features, just we'll try to understand the sum of part of pathophysiology, which will be helpful to understand and remember the clinical features. So here, by the autoimmune mechanism, we have TSH receptor stimulating antibodies, so anti-TSH receptor antibodies, which are the stimulating antibodies, which is common in the 90% cases and increased. And the other less common is the anti-TG antibody and anti-TPO antibody, which are non-specific and seen in about 70% cases. So how does this affect? So these thyroid stimulating antibody will affect the thyrocytes, causing increased thyroid hormones. So that will be having the trophic effect and the secretory effect. So the trophic effect will cause goiter, and the secretory effect will cause hyperthyroidism. So goiter is the swelling and hyperthyroidism is the metabolic effect. So goiter, here the swelling will be diffuse, smooth, and with high vascularity, causing bruit. That is the sound around the swelling. Then the secretory effect causing increased thyroid hormones in the body, causing hyperthyroidism. These will be having the systemic effects like GI symptom, that is diarrhea as we have discussed, menstrual abnormalities, rapid bone maturation, GI symptoms, that is diarrhea. Then the calorigenic effects due to increased thyroid, that is heat intolerance. Then we have sweating, the patient will be having more sweating. Weight loss, good despite good intake. So even after having good intake, they'll be having weight loss, heat intolerance, sweating and weight loss. And lastly, the adrenogenic effects. So they will be having palpitation, may which will be due to atrial fibrillation, and over time they will having congestive heart failure, nervousness, fatigue, emotional liability, and hyperkinesis, tremors, and even eye signs, that is various eye signs which will be seeing lid lag, Dalrymple sign, lid retraction, etc. So these are the adrenogenic effects: the palpitation, nervousness, fatigue, emotional liability, hyperkinesis, and tremors and eye signs. Some of the more points, that is there will be GAG deposition, that is glycosaminoglycans, which will be causing pretibial myxedema, swelling in the leg region. Ocular fibroblast and muscles will be sharing the TSH receptor common antigen, causing ophthalmopathy, that is when there is deposit in the intraocular muscles, the infiltrative eye disease causing periorbital edema, chemosis, proptosis, restriction of the eye muscles, keratosis, keratitis, and blindness. So these will be the features of the eye disease along with some others which we'll be seeing now. So as we have seen, there will be diffuse enlargement of the thyroid, tremors, eye signs. So what are the eye signs? These are exophthalmos, Stelvak sign, that is infrequent blinking. Exophthalmos is protruding of the eyeball. Dalrymple sign, where there will be lid retraction with visible upper sclera. Von Graffi sign, where there will be lid lag on down gaze when the patient tries to see down. And these lid lag and lid retraction occur due to spasm of the Muller muscles, which are the autonomic component of the LPS, that is levator palpebrae superioris, the eye muscles, the eyelid muscles. Then the Geoffroy sign, where there will be absence of forehead wrinkling on the up gaze. Mobius sign, due that will be loss of accommodation reflux. And lastly, the pretibial myxedema, which is dermopathy in the lower limbs, acropathy, that is swelling, dermopathy, and subperiosteal bone formation of the digits. So these are some of the clinical features. Then coming to Graves' disease, the diagnosis of Graves' disease. So the clinical features, there will be low TSH and high T3 and T4 as in the hyperthyroidism, and in the early cases there will be normal T4 but the T3 will be high. So in early cases we have to be careful that even a free T3 which will be high and T4 may be normal. Then thyroid scan, it will be diffuse increased uptake, antibody level, that is TSH receptor antibody, which is more common, and others like the anti-TPO and the anti-TG antibody may also be raised. CT and MRI, which will be useful for checking ophthalmopathy, and histopathology, which will be showing tall columnar cells with scalloping of colloid. Tall columnar cells with scalloping of colloid. Now coming to the management. So in children, we generally manage Graves' disease with drugs only, and in pregnancy again we manage them with drugs only, that is propyl thiouracil only. And adults without goiter, that is no swelling, we can go with drugs with radioiodine ablation, and if the patient has goiter, then we can go with drugs followed by surgery. And in cases where there is more comorbidity and surgery may not be possible, then we can again use radioiodine ablation after drugs. If the patient is having eye signs, then it is generally surgery after drugs, because radioiodine ablation causes worsening of eye signs. So what surgery we go for Graves' disease? So generally we go for total thyroidectomy, although subtotal or near total thyroidectomy is also possible and used sometimes. But here there is less chance of recurrence, whereas in case of subtotal or near total thyroidectomy, the chances of recurrence is more, and so therefore it is avoided. And after total thyroidectomy, so there will be thyroid failure, so we'll have to give thyroid supplements, thyroxine supplements. Also there will be risk of nerve injury and hypothyroidism after both total or subtotal thyroidectomy. So to prevent the chances of recurrence, we generally go for total thyroidectomy, as after subtotal thyroidectomy, if there is a recurrence, it is very difficult to reoperate. So this was all about Graves' disease and its management. Now coming to Plummer's disease, also known as toxic nodular goiter. So here the patient will be having multiple nodules, so it will be a multinodular goiter, and females are more commonly affected, so 5 times more common, and second most common cause of hyperthyroidism after Graves' disease. Management is again with antithyroid drugs, where the patient will become euthyroid, and then we'll go for surgery and thyroxine replacement post surgery. And here we will not be using potassium iodide, because sometimes it can result in Jod-Bezos effect. So this was about Plummer's disease or toxic nodular or toxic multinodular goiter. Then lastly, coming to toxic solitary nodule, solitary toxic nodule, where there will be single nodule which will be more functioning, and it is seen in 5th decade, around 50 to 60 years, and again it will be more common in females. And how do we manage these cases? By drugs followed by radioiodine ablation, because radioiodine will concentrate in the hyperfunctioning nodule and destroy it. And lastly, if required, we'll go for a hemithyroidectomy. So only the part of thyroid which is having the nodule will be removed. So this was all about hyperthyroidism, some of the causes of hyperthyroidism and its management. Hope it will be useful for MBBS and NEET PG aspiring students. And thank you for watching. Keep learning, keep growing, and never give up, because great things take time. And keep studying, keep growing. See you soon in next video. Thank you.